Name Raja Zaidan, age 59, weight 70, date of admission January 17, 2021. Chief complaint high-grade fever and cough for 2 days. History of present illness 2 days cough with expectoration. Nasal congestion, watery to greenish. Nasal discharge, fever, maximum temperature of 39.3, difficulty of breathing. Throat pain. History, assessment, muscular weakness, cyanosis, tachypnea, DOB, coarse crackles, wheezes. Food aversion, loss of appetite, medical history, asthma, hypertension, diabetes. No surgical history. Family history, asthma from the mother's side, diabetes from the father's side. Medication history, Nexium, Forxiga, aspirin. Fluticasone, Spiriva, Concor, singular. Pneumonia is an inflammatory process involving the terminal airways and alveoli of the lung caused by infectious agents. Types of pneumonia: community-acquired, hospital-acquired, healthcare-acquired, and aspiration pneumonia. Community-acquired pneumonia is the most common type of pneumonia, caused by the bacteria Streptococcus pneumoniae, Haemophilus influenzae, and Moraxella catarrhalis, as well as the viruses rhinovirus and influenza. It occurs outside of hospitals or other healthcare facilities. Hospital-acquired pneumonia, or nosocomial pneumonia, refers to any pneumonia contracted by a patient in a hospital at least 48 to 72 hours after being admitted. The difference between hospital-acquired and community-acquired: in hospital-acquired pneumonia, it is usually caused by a bacterial infection rather than a virus. Healthcare-acquired pneumonia is a pneumonia that you get when you are in a hospital or nursing home. It is generally considered more serious than pneumonia that people get in daily life. This is because the person with healthcare-associated pneumonia may already have a serious illness. It is often caused by bacteria that are more resistant to antibiotics, so healthcare-associated pneumonia may be harder to treat. Aspiration pneumonia is a complication of pulmonary aspiration. Pulmonary aspiration is when you inhale food, stomach acid, or saliva into your lungs. You can also aspirate food that travels back up from your stomach to your esophagus. All of these things may carry bacteria that affect your lungs. Healthy lungs can clear up on their own. If they don't, pneumonia can develop as a complication. Pneumonia may be caused by viral infections, bacterial, or fungi, less frequently by other causes. The most common bacterial type that causes pneumonia is Streptococcus pneumoniae. It is characterized by inflammation of the air spaces in the lungs, most commonly due to an infection. Risk factors: pneumonia can affect anyone, but the two age groups at highest risk are children who are 2 years old or younger, adults 65 years or older. Other risk factors include chronic disease such as asthma, COPD, or heart disease. Smoking, weakened or suppressed immune system, people who have HIV or AIDS, who have had an organ transplant, or who receive chemotherapy or long-term steroids are at risk. Signs and symptoms: fever, dyspnea, fatigue, productive cough, and often with pleuritic chest pain. Pleuritic chest pain may be aggravated by respiration or coughing. Dyspnea and tachypnea, use of accessory muscles of respiration, and fatigue. Tachycardia may be present. Diagnostic tests: blood tests. Blood tests are used to confirm an infection and to try to identify the type of organism causing the infection. Chest X-ray. This helps determine the extent and location of the infection. Pulse oximetry. Sputum test. Gram stain and culture and sensitivity of sputum. Well-collected specimen without saliva contamination. Management, antimicrobial therapy, depends on the identification of causative organism and sensitivity to specific antimicrobials. Oxygen therapy, if patient has inadequate gas exchange. Early mobilization, when clinically stable, reduces length of facility stay. Vaccination, assess influenza and pneumococcal vaccination status, and if not currently vaccinated or status uncertain, perform prior to hospital discharge. Smoking cessation, respiratory hygiene measures including the use of hand hygiene and mask or tissues for patients with cough. Treatment depends on the type and severity of the pneumonia. Bacterial, treated with antibiotics. Viral, treated with rest and plenty of fluids. Antiviral medications can be used in influenza. Fungal types treated with antifungal medications. Nursing assessment. Take a careful history. Local epidemiology and patient travel history. History of exposures and local or national outbreaks may help in pneumonia identification. History of recent respiratory illness, complete medical history, and social history, including risk factors for pneumonia, presence of purulent sputum, increased amount of sputum, fever, chills, pleuritic pain, dyspnea, and tachypnea, any pattern of family illness, medications including recent antibiotics, and allergies. Observe for dyspnea, excess fatigue, change in mental status, anxiety or respiratory distress, auscultate for crackles overlying affected region and for bronchial breath sounds when consolidated. Filling of air spaces with exudate is present. Nursing diagnosis. Impaired gas exchange related to decreased ventilation secondary to inflammation and infection involving distal air spaces. Ineffective airway clearance related to excessive tracheobronchial secretions. Acute pain related to inflammatory process. Infection and dyspnea. Risk for injury secondary to complications. Improving gas exchange. Observe for dyspnea, hypoxia, cyanosis, and confusion. This indicates worsening condition. Follow ABG levels or oxygen saturation to determine oxygen need and response to oxygen therapy. Administer oxygen at concentration to maintain oxygen saturation at acceptable level. Use caution with concentrations of oxygen in patients with COPD. Particularly with evidence of carbon dioxide retention. Position the patient in an upright as tolerated to obtain greater lung expansion and improve aeration. Enhancing airway clearance. Obtain freshly expectorated sputum for gram stain and culture prior to antibiotic treatment. Auscultate the chest for crackles and rhonchi. Encourage the patient to do deep breathing and coughing exercises to reduce retained secretions that interfere with gas exchange. Suction as necessary. Encourage increased fluid intake unless contraindicated to replace fluid losses caused by fever, diaphoresis, dehydration, and tachypnea. Humidify oxygen to reduce dryness of mucous membranes. When clinically stable, mobilize patient to improve ventilation and secretion, clearance, and reduce risk of atelectasis and worsening pneumonia. Relieving pleuritic pain. Place patient in a comfortable position, semi-fowlers, for resting and breathing. Encourage frequent change of position to prevent pooling of secretions in lungs and atelectasis. Demonstrate how to split the chest while coughing. Avoid suppressing a productive cough. Administer prescribed non-sedating analgesic agent to relieve pain. Use comfort measures to improve symptom control. Encourage modified bed rest during febrile control. Watch for abdominal distension or ileus, which may be swallowed air during intervals of severe dyspnea. Monitoring for complications. Monitor temperature, pulse, respiration, blood pressure, oximetry, mentation, and for evidence of dyspnea at regular intervals to assess the patient's response to therapy. Auscultate lungs and heart murmurs or friction rub may indicate acute bacterial endocarditis, pericarditis, or myocarditis. Special nursing surveillance for patients with alcoholism, COPD, and immunosuppression, chronic bronchitis, epilepsy, and delirium. Assess the patients for unusual behavior, alterations in mental status, stupor, and heart failure. Assess for resistant fever or return of fever, potentially suggesting bacterial resistance to antibiotics. Patient and family education. Take the entire course of any prescribed medications. Advise patient that fatigue and weakness may persist after pneumonia. Encourage gradual increase in activities to improve ventilation and reduce hazards of immobility. Encourage breathing exercises to clear lungs and promote full expansion and function. Explain that a chest X-ray is usually taken 4 to 6 weeks after recovery to evaluate lungs for clearing and detect any tumor or underlying cause. Advise smoking cessation. Advise the patient to keep up natural resistance with good nutrition, adequate rest, and physical activity when tolerated. Instruct patient to avoid fatigue, sudden extremes in temperature, and excessive alcohol intake. Advise avoidance of contact with people with upper respiratory infections for several months after pneumonia resolves. Respiratory and hand hygiene. Prevention. Wash your hands regularly, eat right, exercise, get enough sleep, quit smoking, and stay away from sick people if possible. Vaccination for pneumococcal pneumonia, recommended for both children and adults depending on their health conditions. Complications: pleural effusion, sustained hypotension and shock, empyema, superinfection, pericarditis, bacteremia, and meningitis. Delirium, atelectasis, delayed resolution. Expected outcomes: cyanosis and dyspnea reduced, ABG levels and oxygen saturation improved, coughs effectively, absence of crackles, appears more comfortable, free of pain, fever controlled, no signs of resistant infection. Nurses play an essential role in preventing hospital-acquired pneumonia, not only by ensuring that all aspects of their nursing practice, but also through nursing research and patient education. Management done in DASH: diagnostic tests, laboratory investigations, CBC, blood culture, sputum culture. Imaging: chest X-ray, CT chest. Medical management: IV levofloxacin, IV ceftriaxone, nebulization Atrovent, Pulmicort, IV paracetamol, prednisolone, Spiriva, Ambroxol, tab singular, and IV fluids. Discharge disposition: follow-up CT is recommended in 4 to 6 weeks to ensure resolution to exclude any possible concealed neoplastic process. Advised to quit smoking. Home medications: tab Tavanic, IM ceftriaxone, tab Diflucan, Relvar, and Spiriva. Follow up in clinic after 7 days.